All right, now we're going to get started. Okay, so this is respiratory day 1. So this is going to start with 10B's chapter 19. It does go into some of the other chapters, but this is where it's going to start. So our objectives today are going to be to describe the purpose of the respiratory system and discuss the parts of the upper and lower respiratory tract. We're also going to differentiate between respiration, ventilation, diffusion, and perfusion. We're going to be able to list the ways in which oxygen and carbon dioxide are transported in the blood, be able to discuss the mechanisms that regulate respirations, and identify elements of the respiratory assessment. This is everything that we're going to cover today. So your respiratory system is divided into 2 parts. You have the upper respiratory tract that includes the nasal cavity, the pharynx, and the larynx. And then your lower respiratory tract starts at the trachea. So your trachea, the primary bronchi, and your lungs. This is all part of the lower respiratory tract. With your upper respiratory tract, you have the nasal cavity. So your nasal cavity includes the nares, the nasal septum, and the turbinates. So air enters the respiratory tract through the nares. And then breathing through your nares instead of the mouth provides better protection for the lower airway. And then the internal nasal nose is divided into 2 nasal cavities that's separated by the septum. So your septum's that the bridge or the middle kind of separating the nares. And then each nasal cavity contains 3 passages called turbinates. And those are those little areas where they're kind of like scroll-like bones. They are able to they warm the air, moisturize it, and are kind of there for as like a cleansing agent. And then your mucous membranes are lined with tiny hairs called cilia. And that just helps get rid of any dust, particles, or they help prevent bacteria from entering the respiratory tract. So your air is warmed, filtered, and moistened as it enters into your nose. And then those mucous membranes that are line the nose are very vascular. So sometimes you'll see little old people will, like when they try to clean their nose or whatever, they dig too far and then they burst one of those little vessels and they get a nosebleed. So with the upper respiratory tract, the nasal cavity opens directly into the sinuses. And the sinuses are hollow areas that kind of make up the skull, and they're lighter. And so this is what affects our voice. So you have your sinuses down here, and then you have your frontal sinus. Your frontal sinuses lie in front of the bone, so above the orbital cavity. So this is your frontal cavity sinus. Your ethmoid sinuses are between the eyes. So when you have like a sinus infection or sinus headache, that's why you kind of feel it in between your eyes. Then your sphenoid sinuses are going to lie directly behind the nasal cavity. And this is where you get all that like pressure up in your head. And then you have the maxillary sinuses that lie on each side of the nose. So this is the sinuses that you'll have here whenever you have a sinus infection. That'll be really painful. And these are all still lined with mucous membranes. And these membranes have immunoglobulins that help fight infection. Also in your upper respiratory tract is the pharynx. This is your passageway for air and food. You can also call the pharynx your throat. It extends from the base of the skull to the esophagus and sits in front of the vertebrae. So on this picture here, you see the nasal cavity that goes down into the nasal pharynx, your oropharynx, and then your laryngopharynx. So this is lines the vertebrae. And so your pharynx is subdivided into that nasopharynx, oropharynx, and laryngopharynx. The nasopharynx is the superior portion of the back of the nasal passageway that leads into the oropharynx. And these contain adenoids. So if you've ever, if your kids or anybody's ever had an adenoid removal, this is where that's from. And then the oropharynx is the posterior of the mouth. Oro as oral, right? So that makes sense. And this sits directly superior to the laryngopharynx. So you have your larynx and then your oropharynx above it. And then, but your tonsils and adenoids don't play necessarily a part in the respiration, but they do help prevent or protect you against infection. So they seem like they don't do anything, but they actually have a big role to play. Your larynx is the organ of voice and it contains your vocal cords. And then you have the epiglottis. That's that leaf-shaped area of cartilage that covers the larynx to prevent food from entering the lungs. And then you have the glottis. That's the opening to the vocal cords. So speech is produced just by passing air over those vocal cords and produces vibration. So whenever you talk, this is just air going through. And your upper respiratory tract is all supported by cartilage or the thyroid cartilage. So in males, they'll have an Adam's apple. And this is that difference that you'll see. Sorry, I'm trying to turn my pages of notes and also talk. The lower respiratory tract contains the trachea or the windpipe. And this is a cylindrical tube that extends to the mid-chest where it divides into the left and right bronchi. And it's supported by a C-shaped cartilage. This just helps prevent the trachea from collapsing. And then the cricoid cartilage is the only complete cartilaginous ring in the nasopharynx. So it's, you hear like medical shows talk about applying cricoid pressure. This is where they're talking about. The trachea, so once you get through the trachea and down to the lungs, you have the carina. Do you remember in nursing one when we talked about doing, when we do a tracheal sectioning, how you need to, if you go too far, they'll start to cough. Well, the carina is very sensitive, and so if you get close to it, or if you're suctioning and your tube hits it, you can cause a bronchospasm. So that's the point where the left and right main stem bronchus kind of bifurcate. So it's very, very sensitive. It can cause lots of suctioning. Also, when you're placing an NG tube, if they start to cough and they'll start to like turn red and cough very hard, this is also a sign that you may be in the trachea and not necessarily in the GI tract. Your lower GI tract, or sorry, your lower respiratory tract, the trachea is lined with mucous membranes and tiny cilia. That cilia is responsible for protecting the lower airway or the lower respiratory tract. So these kind of continuously sweep dust and debris upward towards the nasal cavity, and this is what causes you to sneeze and have all the drainage that you will. Your lower respiratory tract has the right and left main stem bronchi. So the right bronchus is shorter, wider, and straighter than the left. So oftentimes whenever you are when somebody's being intubated, they'll enter the right bronchus before they'll go too far and enter that right bronchus. And you're typically, since that's shorter and wider, you're typically going to develop more aspiration pneumonia there, just because it is wider and so fluid will pool there. And then the left bronchus is smaller in diameter and is slightly more horizontal than the right part of the side. The lower respiratory tract contains the bronchioles, and these are bronchioles that are in the alveolar ducts. So you have the right and left bronchi divided into bronchioles. And this is divided and called the hilus. And these structures are lined with a ciliated membrane, kind of like the trachea does. And then those bronchioles divide into smaller tube-like structures called the alveolar ducts. And at the very end of the terminal bronchioles are the alveoli that resemble a cluster of grapes. So if you think about your lungs like a tree, where the main trunk is the trachea, the tree trunk branches into large branches that then divide into the smaller branches of a tree. So if you think about your lungs like that, you just kind of flip it upside down. So you have your trunk, and then your limbs and your larger branches, and then your leaf sections. So that's just the easiest way to think about it. Your lower respiratory tract with your alveoli, like I was talking about, these are your functional unit of the lungs. This is where gas exchange takes place. So you remember us talking about ABGs and how they can help monitor gas exchange? This is what that's talking about. It is the most important unit in the lungs. If you have alveolar collapse, then you don't really have good respiration. So adult lungs contain about 300 million alveoli. So each alveoli consists of a single layer of the squamous epithelial cells that have very thin walls, and they're surrounded by small capillaries where diffusion of oxygen and carbon dioxide occurs. So your number of alveoli remains stable with age, but the walls start to become thinner and contain fewer capillaries. So your gas exchange is actually decreased. So sometimes whenever you are listening to your patient's lung sounds and you hear like popping sounds, that can be the alveoli kind of collapsing and they're making noise that way. There's also something called surfactant. So each of your alveoli are covered with a thin layer of surfactant. Surfactant is a lipoprotein that's secreted by the cells of the alveoli, and they prevent them from collapsing. But if you have an insufficient amount of surfactant present, then your alveoli are going to collapse, and that's called atelectasis. So your alveoli give shape and form to the lungs, and the surfactant helps stabilize those alveoli. Your lungs, if you filled it with air, could float on water because there's so much air pressure in there and they're very light. The respiratory system, the lungs are large, paired, spongy, cone-shaped organs. Sorry, I'm trying to turn my page and it's not working very well. The right lung is divided into 3 lobes, and then the left lung has 2 lobes. And then you have the apex, that's a superior portion of the lungs. So that's that narrow part. So it's approximately an inch above the first rib. So you think of the heart, the apex is at the lower portion because that's where the point is, but in the lungs, it's at the top or the upper part. And then you have the base of the lung. So that's the inferior portion of the lung that lies in the diaphragm. Issue. Fine.
They didn't have any pink drinks.
Oh, they didn't?
They don't do that anymore.
That's rude. So our coffee shop doesn't do pink drinks anymore. Just fun fact. And then in the thoracic cavity, we have the chest wall. So you have the ribs, and this is what gives your body shape and support. You have 24 ribs total. And your ribs are kind of like that protective barrier for your heart and lungs. So if you think about like a vehicle, your vehicle is kind of like your rib cage. It protects the what's inside from accidents and things like that. Then you have the sternum, and that's just that larger, flatter bone in the center that connects the ribs. So your thoracic cavity is going to contain your heart, your lungs and your other major vessels. So you think of like your aorta and all that stuff. But you need to know the mid-sternal, mid-clavicular, and anterior line when you're assessing. So mid-sternal is in the middle. The mid-clavicular line is right in the middle of the clavicle. And then the anterior axillary line is closer to your armpit, essentially. The pleural cavity has, so your lungs are going to occupy almost all of the thoracic cavity itself. So you have the parietal pleura, that's the outer layer of the lungs, and it lines the chest cavities, and that has pain fibers. So when you have inflammation of that membrane, that's called pleurisy, and it causes severe pain, which we call pleuritic pain with each breath. So as you start to take breaths in, when you have pleurisy, that's going to cause a lot of pain. Then you have the visceral pleura, and this is the membrane that lines the surface of the lungs, and it does not have pain fibers. And then your intrapleural space or your pleural space is fluid. So it's that fluid in between the pleural and visceral layers of the lungs. So think about your heart where you have the pericardial sac and then the myocardial tissue, that layer in between. That's your that space. It's similar to what your lungs have. But these contain a negative pressure. So your air in the lungs have a higher pressure than the pleural cavity, and that's what helps keep your lungs inflated. And then we'll talk about disease processes that occur and why you may need like something to allow air to escape. And then the parietal and visceral pleura produce serous secretions. It has two responsibilities. This provides lubrication for the respiratory tract and also increases cohesion between the pleural layers. When you have a pleural effusion, this is when fluid gets built up in that space. And it can become infected. It can like compress your lungs. So you may need something called a thoracentesis, where they go in and put like a tube into that space and they draw out the extra fluid. If that fluid is infectious, that's what's called an empyema. And this is when you have purulent parietal fluid in there. So if you have an infection, it's called an empyema. If you have a buildup of excess fluid, then you need a thoracentesis to drain it. And we'll talk more about that here in a second. So when we breathe, you have a diaphragm. The diaphragm is what mainly helps with respiration. It's dome shaped, so when your lungs expand, or when you breathe in or out, your diaphragm is either gonna contract or concave. So when we take a breath in, our lungs expand or increase in the size, and that's because our lungs are contracting. And then when we blow out, so when you take a big deep breath in, everything, you're kind of increasing the pressure in there, so the diaphragm will increase. But whenever you blow it out, you can feel your diaphragm kind of push everything back up. Your intercostal muscles, so whenever so each rib has protected by costal muscles, and then the muscles in between each rib is called the intercostals. This is what helps increase the size of the thoracic cavity whenever we breathe in. These are all muscles. And then when air is pulled into the lungs, we have a decrease in pressure. Costa is just Latin for ribs. And so those intercostal muscles are found in between those ribs. So whenever somebody gets a chest tube or something like that, we're putting that tube in between or in through those intercostal muscles. Now we're going to kind of put it all together. So during inspiration, the diaphragm is going to contract, pushing the abdominal contents downward. So when you take a big deep breath in, it's going to push everything down. And then at the same time, those intercostal muscles are going to contract, increasing the lateral and anterior posterior dimensions of the chest. And this causes the size of the thoracic cavity to increase and the intrathoracic pressure to decrease. So air is able to enter the lungs. And then inspiration is active. So you have to actively inspirate, and then expiration is passive. And these are just some terms that you'll need to know. This is all related to respiration. So ventilation is the movement of air in and out of the lungs. Inspiration is the movement of oxygen into the lungs. Expiration removes CO2 out of the lungs. Diffusion, you remember from IV therapy, is a transfer of a substance from an area of higher concentration to an area of lower concentration. And then perfusion is the circulation of blood through the tissues. So one respiratory cycle, you have one inspiration and one expiration. That's one complete respiratory cycle. So inspiration, like I said, is an active process, and then expiration is passive. Normal respiration for an adult at rest is between 14 and 20. If they are on narcotics, their respirations may be less than 14, but you still want to monitor that. If they're having breathing difficulties, and then they're going to be above 20. So between 14 and 20 is normal. So whenever you're doing assessments, should you count respirations? Should they be talking? Do you want to tell the patient that you're counting respirations? If patients know that you're counting their respirations, they tend to change the way that they're breathing. So they'll either quicken their breathing or they'll lessen it. So whenever you're palpating your pulse, that's when you also want to take a little bit of time and count the respirations. External respiration is the exchange of gases with the external environment and occurs in the alveoli of the lungs. Internal respiration is the exchange of gases within the internal environment and occurs in the tissues. And then do you remember where those exchange of gases occur? They occur in the alveoli. And then you have respiratory drive. That's the intensity of the output by the respiratory centers and determines the effort of respiratory muscles. So your respiratory drive to breathe, if you are short of breath, your drive, you're going to increase. So you're going to breathe faster to get more oxygen where you need it. And then do you guys know how oxygen is transported in the blood? Like which component of the lab you're looking at? That's going to be your hemoglobin. So oxygen binds to hemoglobin and is transported throughout the blood. So with respiratory drive, if you have a respiratory disease, you have so a person without a respiratory disease, like if you're healthy, you have a normal respiratory drive to breathe. So you breathe because that's what's normal to breathe. And then your respiratory drive regulates the average rate of respirations. So in healthy individuals, as it increases the concentration of carbon dioxide in the blood stimulates us to breathe, which brings more oxygen in and releases CO2. But if you have something called COPD, which we'll talk about later, you have a hypoxic drive to breathe. So the body's adjusted to the amount of CO2 in the blood. And so this can lead to low oxygen levels being a stimulus for a patient with COPD to breathe. So if you have a patient with COPD and they get oxygen at 2 liters per minute, the drive to breathe then can be eliminated. So oxygen can depress the respiratory drive to breathe. So you have a patient with COPD, you don't want to increase their oxygen level because that can actually decrease their drive to breathe. I know it seems kind of counterproductive, but if you have a buildup of CO2, then more oxygen is just going to it's going to make you retain more CO2. And then if you guys remember back when you talked in neuro, the drive to breathe or in the control of ventilation is all in the medulla oblongata and the pons. And those are your central chemoreceptors. Do you remember what chemoreceptors are? Chemoreceptors send nerve impulses to the respiratory centers in the brain to modify respiratory rates in response to increasing blood CO2 levels, which decreases blood oxygen levels or increasing blood acid levels. Then you have peripheral chemoreceptors, and this is the rhythm and rate of respiration can change depending on the needs of the body. So carbon dioxide in the blood is the chemical stimulant for regulation of respiration. And then oxygenation of the blood. If you remember in cardiac, we talked about the blood flow through the heart and when it goes to the lung. Deoxygenated blood enters the lungs, it becomes oxygenated, and it gets shipped to the rest of the body. So blood that's reached the alveoli through the pulmonary arteries is low in oxygen, but high in carbon dioxide. So oxygen and CO2 move back and forth across the alveolar capillary membrane by diffusion. And then most of the oxygenate is transported in the blood bound to hemoglobin in the red blood cells. If you don't have oxygen bound to hemoglobin, then you're going to start seeing cyanosis. And cyanosis is just that bluish or grayish tint to the skin. And then where might you see cyanosis? So you can see it around the lips, you can see it in the nail beds, you can see it in their mucous membranes. Their mucous membranes will become very pale. So those are all things to think of whenever you're doing assessments. Pulmonary perfusion. So you have the lungs have two different types of circulation. You have pulmonary circulation and bronchial circulation. With pulmonary circulation, this provides the lungs with oxygen for gas exchange. And then pulmonary circulation occurs when the deoxygenated blood enters the lungs through the pulmonary artery, and then oxygen-rich blood leaves the lungs back to the heart. And then there are some factors that can affect this. This includes gravity, alveolar pressure, and pulmonary artery pressure. So if you have lung or cardiovascular disease, a decrease in pulmonary artery pressure can cause a decrease in perfusion to the lungs. And then you have bronchial circulation. This is part of the cardiovascular and systemic circulation, which provides oxygen to the bronchi and the trachea to allow for adequate perfusion. So no oxygen exchange occurs in the bronchioles, but it does occur in the alveoli. But bronchial circulation is necessary so that pulmonary tissue has adequate oxygen for pulmonary circulation. So all of this is just a continuous process. So every time you breathe or blood is pumped in your heart, all of this stuff is happening all at once. So there are some problems in the respiratory physiology. You can have respiratory insufficiency. And this develops due to either an interference with ventilation, diffusion, or perfusion. And this can result in hypoxia, hypoxemia, hypercapnia, and hypocapnia. And then if you remember from earlier, what ventilation, perfusion, and diffusion is, remember ventilation is the movement of air in and out of the lungs. Diffusion is the exchange of oxygen and CO2 across the membrane, and perfusion is the transfer of oxygen to the cells. But if any of those symptoms or systems fail, then you can have hypoxia, hypoxemia, hypercapnia, and hypocapnia. Hypoxia is decreased oxygen and inspired air into the cells. Hypoxemia is a decrease in oxygen in the blood. Remember, emia is always going to mean blood. Hypocapnia is decreased carbon dioxide in the blood, and hypercapnia is when you have an increase in CO2 in the blood. And then you can have things that affect how your lungs comply with gas exchange. So there's something called sarcoidosis or asbestos. Sarcoidosis is just a lung disorder that affects how we breathe and circulate blood. And then asbestos causes an alteration in the lung tissue. So if you see those commercials that talk about, like asbestos exposure and how it can cause problems, this is all just issues that can occur with, like within the lungs. And then there are some gerontologic considerations. So they're older adults. Cartilage in the nasal septum increases in length and can harden. So as we get older, things, lose elasticity. So your cartilage in your nose will start to lengthen. That's why when we get older, our nose grows. And that cartilage can harden and that can change the way air flows. Because we don't have as much elasticity, then we can have a change in how airflow goes in through our nose and through the turbinates. Your alveolar walls also become thinner and contain fewer capillaries. This decreases gas exchange. Your lungs will lose elasticity, so you don't breathe as well. Even with muscle tone. So as we age, our muscles kind of contract and they don't work as well. So if you think about the intercostal muscles, those start to become weaker, and that can decrease how well we can expand our lungs. Our muscle tone is going to change, our cough reflex, and the amount of cilia we have is going to decrease. So then we're at an increased risk for respiratory disease. So if we can't breathe like we normally would, and the muscles to the tissues are more rigid, it's all going to affect like how we breathe on a daily basis. All right, now we're going to assess the respiratory system. So when we assess, we are always going to look for subjective data. So this is the things that the patients are going to tell you. Are they telling you that they're short of breath? Do they have a cough? And then your objective data are the things that you're going to assess. So this is like your head to toe assessment. And then you also want to look at their medication history. So what medications do they take every day that we would want to be aware of? Do they take certain medications that are supposed to increase their the way that they breathe? Is it going to increase their respirations? Things like that. When we listen to the lungs, if you remember way back to first semester, you're going to use the diaphragm of the stethoscope and you're going to use your landmarks. So you have 10 points on the front and 4 points on the side. So your front and back should be the same, and then you have 4 points on the side. And then you're going to kind of step. So you're going to have 1, 2, 3, 4, 5, 6. So you're not going to like go 1, 2, and then go to the other side. You're going to kind of step ladder each side. There are different breath sounds. So you have vesicular breath sounds, and that's when you have air movement in the bronchioles and the alveoli. You can hear these over all the lung fields, and they're going to be kind of a quiet and low pitch sound. You're going to have a longer inspiration and shorter expiration. So it's kind of very quick lung sounds or breathing sounds. Then you have bronchial sounds. This is when you have air movement through the trachea, and you're going to have a loud, longer expiration. So the way that we breathe is going to be longer and louder. And then you have bronchiovesicular, and these are heard between the trachea and the upper lungs. These can have a medium pitch, and they're going to be equal on inspiration and expiration. Crackles, or also called rails, are going to be fine, medium sounding, coarse. So it's going to sound like a crackling or a bubbling, or like if you take your hair and roll it between your fingers and like put it close to your ear, that's kind of what it'll sound like. This is all caused by fluid, mucus, or pus in the small bronchioles and alveoli. And I have videos listed here to listen to fine crackles and coarse crackles. So you can listen to this on your own time. Then you have sonorous wheezings, also called rhonchi. These are low-pitched, coarse snoring sounds. And these are caused by a narrowing of the tracheobronchial passages due to secretions. If they have an increase in secretions, if they have a tumor in that part of the lungs, or if they're having lung spasms. If they cough, these can clear if it's due to secretions. And I've got a video listed here for rhonchi. Then you have sibilant wheezes, which most people just call wheezes. And these are high-pitched, almost musical sounds. They can sound like a whistle during inspiration and expiration. These are caused by narrowing the bronchioles due to a tumor. It can be due to a bronchospasm. So if your patient has asthma, you may hear those bronchospasm sounds. Or if they have foreign matter. So if you have aspirated like a peanut or aspirated some kind of fluid, then you you'll hear wheezes with this sound. And this is another video that you guys can listen to. And then you have a pleural friction rub. This is like a dry creaking and grating sound. It'll be lower pitch, but it'll almost sound like mechanical. And this is because by an inflammation of that pleural space. So when that pleural fluid is either decreased, and then you have the two tissues kind of grating against each other. This is what that's going to sound like. And I've got a video here that you can watch to see the difference in those. And then you have stridor. Stridor is typically something you want to be very mindful of. It's very high pitched and musical, and it's caused by a blockage or a narrowing in the upper airway. So typically it's going to be in your throat or the larynx. And I've got a video here also. So stridor requires emergency intervention. And stridor occurs because your patient's not getting sufficient airflow. So if we're not getting good airflow, we're not getting good oxygenation, which is going to lead to poor perfusion. And then eventually, if those bronchioles and things start to become completely occluded, then we don't have any respiration. So then we're going to have major trouble with that. So stridor is an emergency. If you have absent breath sounds, so you can't hear any sound over the entire lung or any areas of the lung, this can be caused by a pleural effusion. So it'll make those sounds sound very distant or diminished. You can have a main stem bronchus obstruction. You can have a large amount of atelectasis in the lungs. If someone has had a pneumonectomy or like a lung removal, you won't hear any breath sounds because there's nothing to make those sounds there. Or if you had a lobectomy, so you may hear upper lung sounds but no lower lung sounds because they've had part of that lung removed. Then there are different types of respirations or acousmals. You'll often see this in your diabetics, and it's kind of like a and this one you'll also notice that they have a fruity breath. This is going to be your diabetics. And then you have Cheyne-Stokes breathing. This is when they're near death. So they'll have a pause in breathing, and then they'll have like a slow increase, and then they'll stop. This is when somebody is very close to death. Then you have tachypnea. That's that very rapid breathing. I'm not going to demonstrate that because I'm going to get dizzy and pass out. And then you can have bradyapnea, and this is when you have very slow breathing. So this is when your respiratory rate is going to be less than 14 or sometimes even less than 12. And then you have biots breathing, and that's very irregular. So that can be either because they have an obstruction or they have some kind of respiratory disease that's causing that. So you need to know the differences in all these. With hypoxia, you remember that's just a decrease in oxygen. Early signs, your patient's going to be restless, they're going to be very anxious, and they're going to have be tachycardic and tachypnea. Late signs, you're going to have bradycardia, extreme restlessness, and dyspnea. So your acronym for early is RAT, so restlessness, anxiety, and tachycardia. And then late signs are going to be your bradycardia, extreme restlessness, and dyspnea. So if you think of the acronyms RAT, bed, RAT is early, late to bed. And then in pediatrics or children, you're going to have a feeding difficulty. So because their work of breathing is increased, they're not going to be able to feed as much because when they feed, typically with a bottle or breast, we're obstructing part of their breathing. They're going to have inspiratory stridor. Kids are they're going to have nasal flaring. They're going to have grunting even. And then you'll see sternal retraction. So in pediatrics, it's fines. These are some signs of inadequate oxygenation that can be either a decrease in energy, they'll be very restless. You're going to have rapid, shallow breathing, rapid heart rate. They're going to need to sit up to breathe or even like sit up in a tripod position where they're leaning forward. They're going to have nasal flaring. They may use accessory muscles, and that's your nasal flaring. That's using the muscles in your chest to like breathe in to kind of get air in. You're going to be hypertensive because that's a lot more pressure to get the air in. They could be very sleepy, confused. They can be in a stupor or coma, and that's all just from like a lack of oxygenation. And then you can have cyanosis of the skin. So in your darker skin clients, you're going to look at their mucous membranes. You can look at their nail beds and their lips. So when you're doing a respiratory assessment, you want to know what's abnormal. So is their breathing labored? Are they using any respiratory muscles? Can you hear them breathing? Or are their nares flaring? You also want to assess their fingernails and toenails. So if you have inadequate oxygenation, you can have clubbing of your fingers. And this is a chronic change. So a lot of your COPD patients will have a clubbed finger. So whenever they put their nails together, they'll be kind of pushed out instead of being closer together. So if you put your nails together, you should see you'll see like this opening, but if you have clubbing, it's almost like they're going to be like pushed out to the side. And their nail beds are going to look different. I talked about a little bit about accessory muscles. When you have accessory muscle use, this is just an acute need for oxygen. So you have the pectoralis minor and the sternocleidomastoid. So the sternocleidomastoid is right there around the neck. And then you have the trapezius muscles and the scalenus muscles. You'll kind of see those sink in every time they breathe in. And then there are diagnostic tests and therapeutic procedures. So a chest x-ray is going to provide visualization of the lungs, ribs, clavicles, the humerus, the scapula, the vertebrae, heart, and major thoracic muscles. So this is going to allow you to see your cardiac silhouette, how much air is in the lung tissue. But for a chest x-ray, they have to be in a hospital gown or anything with no buttons or any metal. If they're wearing a bra that has underwire, they have to take those off because it'll show up. And if they're on telemetry, those pads are going to show up. So if they need to really look at it, they may pull off those telemetry pads. There can be no metal between the neck and the waist because it's going to pick up. It'll be very bright white. You also don't want to check your female patients to make sure that they're not pregnant because we don't want to expose unnecessary radiation to the fetus. Then you have a CT or computed tomography. This is used to diagnose lesions that are difficult to assess by X-rays. So an X-ray, you're going to be able to see the silhouette of the organs. With the lungs, because there's so much air, you can see if there's a buildup of fluid. But it's not good for seeing like the tissue itself. So it's good to see if you have bone injuries, lung or chest problems. A CT is going to be good to look at to rule out cancer, or if you have some type of infection. CTs are often going to be used in emergent situations because they take a very short amount of time. You put the patient on the table, they get put in. Usually takes less than 5 minutes to do. And it's less expensive than an MRI. MRIs are very, very expensive. With a CT, you can see bones, soft tissue, and blood vessels all in one scan. But your CT dye, if you need it, it's more likely to cause an allergic reaction than the MRI contrast. So if somebody's going to get CT dye, you want to make sure that they're not allergic to shellfish or iodine. And if you have a metal implant, you can have a CT. It's just MRI that you have to be very careful of. So if you have like a pacemaker or an implanted defibrillator, you can still have a CT. You're not going to run that risk. Then there are ventilation and perfusion ratios. This indicates the effectiveness of airflow within the alveoli and the adequacy of gas exchange. This is also called like a VQ lung scan, and it can help detect pulmonary embolisms, pneumonia, atelectasis, tumors, if you have a mucus plug, if you have a pulmonary infarction or where your lung tissue is just not working, acute respiratory distress syndrome, and a pneumothorax. So you can use a VQ lung scan for that. Often you're going to see that used for a pulmonary embolism. This is how a VQ lung scan will work. It's going to see how oxygen and stuff is like perfused through through like your bronchi, your alveoli. It can look for if there's blockage of the alveoli. So it's a very handy tool. You can also do pulmonary function testing. This is to assess the presence of severity of the disease in large and small airways. It can assess the lung volume. So it's you want to completely exhale all your lung volume after you've taken a big deep breath in. It's going to assess your ventilation. So it's going to evaluate how much air is inhaled or exhaled with each respiratory cycle. There's also pulmonary spirometry, and this is the amount of air that can be forcibly exhaled after maximum inhalation. And this is also going to look at gas exchange. So this is going to determine the degree of function in the pulmonary capillary beds in contact with functioning alveoli. I will give you guys my notes because there's not any test questions on here, just so you have my notes because this is a lot of information to take in. And then with your respiratory system diagnoses, you can do a bronchoscopy. And this is where they thread a scope into the trachea and into the bronchi. They're going to do a local anesthetic or general anesthetic. And this is where they can look for abnormalities. They can do tissue biopsies, and they can collect secretions for an exam or a culture. But with this one, they have to be NPO 6 to 8 hours prior. And then after this is done, they have to be NPO until their gag reflex returns. Because what happens if we give somebody food or drink that they don't have a gag reflex? So if they don't have a gag reflex, if they aspirate any of that food, or they can't tell where it's going, then we can have, something get into their lungs, and then they develop a pneumonia from that. I also want to assess for signs of laryngeal edema and laryngeal spasms and hemorrhage. So if they start to cough, you want to make sure that there's no blood. If they have a biopsy, they may have a little bit, but they should not have profuse amounts of blood. So you also want to make sure that they're not having any stridor, or that they are having any other respiratory deficits after this procedure. A sputum specimen is going to be obtained for microscopic examination. If they suspect some type of bacterial pneumonia, they'll do a sputum specimen, or if they suspect a fungal disorder. This has to be brought up from the lungs, so you can't just gather spit from the back of their throat. It has to come from the lungs. You want to collect these before meals. And with these, you need at least 1 to 3 meals of sputum. A lot of facilities, your respiratory therapists are going to collect these. I know when I worked at St. Bernard's, respiratory therapist always collected these. We didn't. Before they start to collect these, they need to rinse their mouth. Why would we not want food, to have food before we collect it? We don't want any food particles in there, because that can cause a false positive or a false negative. So with the sputum specimen, we're going to inhale and exhale deeply 3 times. We want them to cough forcefully and expectorate into a sterile cup. Early morning samples are going to be more ideal, because they've not had time to build up other things throughout the day. So morning samples are best. You may need a thoracentesis. This is a surgical perforation of the chest wall and pleural space with a needle for the aspiration of fluid. So when you have like an empyema, or you have a buildup of fluid in there that's causing compression of the lungs, we may need to go in and remove it. So this can be used to diagnose, or it can be therapeutic. So sometimes if we think that somebody may have lung cancer, they can pull this fluid from the chest wall, and that can tell us if they have a type of cancer or buildup of bacteria. They will need informed consent for this, because this is an invasive procedure. You're going to have them sit up on the side of the bed with their arms resting on a pillow, so like this picture shows. You want to monitor their vital signs, their appearance, and their respiratory status before, during, and after the procedure. So if they start to become tachypnic, or if they develop tachycardia, or they're using accessory muscles, then you want to monitor that and notify the provider. Once this procedure is done, you want to place them on the unaffected side after the procedure. So we want to make sure that side is getting good inflation, but we don't want to cause any undue pressure on that side. We always, always, always want to monitor these patients during and after this procedure. Another one that you guys do every day that you're at work or at clinical is monitor their pulse ox. This measures the amount of light being absorbed by oxygenated blood and deoxygenated hemoglobin. So you can put this on your fingertips, your toes. If they have like something like nail polish on, or they're not getting good oxygenation, you can put it on their earlobe. You can also put it on their nose, or you can also run a strip across their forehead. This is just a quick, non-invasive way to assess their pulse ox. And the SaO2, or the saturation oxygen, refers to the oxygen bound to hemoglobin. So if you think about somebody that has a hemoglobin of like 6, are they going to have as much? Are they going to have a good SaO2 or not? So if they don't have as much oxygen bound to that hemoglobin, their SAT may be lower. You can also do arterial blood gases, and these just report the status of oxygenation and acid-base balance of the blood. You guys remember when we did this in IV therapy? So it's just going to kind of be an overview. pH is technically the amount of free hydrogen ions. PCO2 is the partial pressure of carbon dioxide. PaO2 is the partial pressure of oxygen. HCO3 is bicarb. And SaO2 is the amount of oxygen bound to the hemoglobin compared to the amount of oxygen the hemoglobin could carry. So this is an ideal measurement. So whenever we do ABGs, we look at the pH. We want to look at the PCO2 and the bicarb. That's all we're going to look at whenever we assess these. So your normal values, if you remember, the pH is 7.35 to 7.45. Your PaCO2 is 35 to 45. Your PaO2 is 80 to 100. Your bicarb level is 22 to 26. And your SaO2 is 95 to 100%. With your ABGs, you can have a respiratory or metabolic syndrome. In respiratory, your PaCO2 will be abnormal. And with the metabolic, your bicarb will be abnormal. So if you are looking at an ABG, if you have a respiratory disorder, your PaCO2 will be, or your PCO2 will be abnormal. If it's metabolic, your PaCO2 will be normal, but your bicarb will be abnormal. And then you have your acidosis versus alkalosis. If you're going to be acidotic if you're 7.35 and higher. If you're alkalotic, you're going to have a pH of 7.45 or higher. So if you're right on the line, if you're like a 7.36, but your PaCO2 is abnormal, then you can almost have like a mixed combination. So, well, let's look at these ABGs. Your pH is 7.13, PaCO2 is 75, PaO2 is 90, your bicarb is 22, and your SaO2 is 86. So what do you think this is? So we're going to look real quick. Your pH is acidic. Your CO2 acidic, and your bicarb is normal. So this is going to be a respiratory acidosis that is uncompensated. So it's uncompensated because our pH level is abnormal. Okay, now we're going to talk about acute respiratory disorders. So rhinitis coryza is also known as the common cold. This is when you have an inflammation of the nasal mucous membranes. So that you can have acute and chronic. You can have allergic and non-allergic. Most common cause of rhinitis is the rhinovirus. And like I said, I'll give you guys all my notes on this because I have notes that I don't have printed. So common signs and symptoms are going to be red, itchy, and watery eyes, sneezing, congestion, and a runny nose. They're going to have an itchy, sore throat, and they can have post-nasal drip and a cough. They may also have a low-grade fever. You're going to have excessive nasal drainage or runny nose. You have nasal congestion. You can have red, inflamed, and swollen nasal mucosa. So if you look at this picture, you've got what a normal airway passage is going to look like versus somebody that has rhinitis. So it's very inflamed. And then you have itching of the nose, throat, and ears. You can develop a headache, have muscle aches, and malaise. Treatment is just to avoid allergens. So if you have an allergic rhinitis, if you're allergic to cats and develop rhinitis, you want to make sure that you are either properly medicated or you're avoiding that allergen. You can take antihistamines. You may even need to take a decongestant. If severe enough, you may have to take an oral or intranasal corticosteroid. You may need an analgesic, a cough suppressant, an expectorant. And if you have a lot of congestion, you can use a hot pack over those facial sinuses, and that'll help take some of that pain away. Good nursing education is to wash your hands. You want them to increase their fluids, and they need to rest. They can use a vaporizer to kind of help put more moisture into the air. They need to make sure and cover their cough when sneezing. And they need to take vitamin C and zinc. They can also do allergy testing. So there are different types. They can do a scratch test, or so they'll take a lancet with the suspected allergen, and then they'll do it on your arms. On kids, they do it on their back, and they'll test different allergens, and they'll look to see if it's positive, you're gonna have this area that's red and swollen. Sinusitis is when you have an inflammation of the sinuses. You can have acute, subacute, or chronic. It can be viral or bacterial. And you can often develop sinusitis after an upper respiratory infection. So signs and symptoms are nasal congestion, headache, facial pressure or pain over the sinus region, tenderness upon palpation to the forehead, orbital, or facial area. So when you go to the doctor and they palpate your face and your forehead, it's going to be very, very tender, and that's just because all that area is inflamed. You can have a cough, bloody or purulent nasal drainage, and you can have a low-grade fever. To treat this, you can do nasal decongestants like phenylephrine, or you can use a vasoconstrictor intranasal spray called Afrin. You may need a broad spectrum antibiotic like amoxicillin. You can use analgesics to help reduce any pain. And you may even need oral or inhaled corticosteroids to kind of help decrease the swelling. Nursing care, you want to do warm mist vaporizer and warm moist packs. You want to increase your fluid intake and rest. You want to discourage any flying, swimming, and diving. So you don't want to disrupt any of the pressure inside those nasal passages. And you want to quit using tobacco. Tobacco, like smoking and stuff, burns that cilia in your nose. And so you're more likely to develop allergens and get bacteria and stuff like that into your sinuses. They do have surgical interventions if it becomes severe enough. So there's a functional endoscopic sinus surgery, or a FES procedure. And this is minimally invasive for serious sinus conditions. So the surgeon can remove any tissue or obstruction that's blocking the sinus, especially if you have swollen or infected tissue. And there's also the Caldwell-Luck procedure, and this can remove irreversibly damaged mucosa of the maxillary sinus. And here are pictures of these. So the FES procedure, they run a balloon device up there, and they pull out all that secretions and some of that tissue and remove it. With a Caldwell-Luck procedure, they go in and make a incision in your above your gums and your teeth, or just above that area, and they go in and cut it open and remove all of that infected tissue or tissue that no longer works, and then they stitch it up. Influenza, this time of year, we're always very familiar with it. Typically, you're going to see this in your fall and winter months. It's very, very contagious, and it's considered a viral infection. And there's influenza A, B, and C. And then you have a pandemic influenza, which is your H1N1, which is the viral infection that mutated from animals or birds, and it is also very highly infectious. With influenza, you're going to have fever and chills, a severe headache, myalgia or muscle aches, fatigue and weakness, severe diarrhea and cough if you have the avian flu, and hypoxia. These are all signs and symptoms. So if you have a patient with influenza, you need to put them on droplet and contact isolation. So you'll need to wear a gown and a mask. They need to stay hydrated, so you're gonna monitor their eyes and nose. So need to drink lots of fluids. Your vital signs, you're gonna focus on the respiratory status. So are they, breathing faster than 20 times a minute? Are they breathing slower than that? You also want to recommend them to get their annual influenza vaccination. Teach them about proper hand washing and cough etiquette. And they need to avoid close personal contact with individuals who are not sick. They can be treated with antivirals. So there's ribavirin. There's zanamivir, which is an oral inhalant, and then there's oseltamivir. So you can do antipyretics and analgesics also. With vaccines, there are trivalent and quadrivalent vaccines. So your standard flu vaccine is inactivated, so that's your shot. It's inactivated, so when people say that they got the flu from the flu vaccine, that is factually not true, because it's not a live virus that you're getting. If you develop the flu after a flu shot, it's because you were already exposed. And then flu mist is a live attenuated vaccine, so it's a live virus. So you have to be very careful with that one. It's not for everybody, especially if you have underlying medical conditions like diabetes. If you have a history of asthma, this can actually make it worse. If you are on immunosuppressive therapy, or if you are immunodeficient, then you can't take the flu mist. If you've had a history of Guillain-Barré, you cannot take flu mist. If you have a hypersensitivity to eggs, I think they've changed the flu mist now. The flu mist is you can't have it if you're hypersensitive, but the vaccine, the shot, I think they've made it to where they don't use the egg compounding. If you're a child under 2, you cannot have the flu mist, or if you're over 50. Pregnant people should also not get the flu mist because it is a live virus. If you're a child from 2 to 17 that take aspirin or products that contain aspirin, you cannot take flu mist. So typically you're not going to give children aspirin, but there are certain medical diseases or disorders that they require children to take aspirin. And then pneumonia. This is an inflammatory process of the respiratory bronchioles and the alveolar spaces that cause infection. So this is when you have a buildup of fluid that can become infected, leading to bacteria. It can be a virus, it can be a mycoplasma, it can be fungus, it can even be a parasite or chemicals. So if you think about housekeepers that work with a lot of different chemicals, they are exposed to more. And if they are exposed to new things, then they can develop a chemical pneumonia. It can be hospital acquired, community acquired, and ventilator acquired. It can also occur if you are over sedated, if you have inadequate ventilation, or if you develop aspiration. So pneumonia can be caused by all kinds of things. You can have factors that predispose you to pneumonia, things like aging, air pollution, if you have an altered level of conscious. So when you are unable to take those good deep breaths in and out, that can cause problems. Prolonged immobility. So if you're laying flat for long periods of time, your lungs aren't getting that good expansion, and then you're going to develop a pneumonia from that. Smoking. It's going to cause a constriction of the airways, and therefore if stuff gets into the lungs and settles, then it can cause, problems there. Upper respiratory infections. You can have a post upper respiratory infection pneumonia. And then if you are immunocompromised, So if you're taking a medication that's making you immunocompromised, or you have a disease process that can cause that, then you're more likely to develop pneumonia. So some pneumonia signs and symptoms, you're gonna have a productive cough, you're gonna have chills, you're gonna have a temperature greater than 100. You may have an increase in heart rate, increased respiratory rate, and shortness of breath. Here's just a little picture that can kind of show you the signs and symptoms of what can cause it. Diagnostic procedures, you can do a sputum culture and sensitivity. So if you have a lot of like a productive cough, it can look to see if you have a fungus or some type of bacterial pneumonia. You can do a chest x-ray to see how far involved it is. Even a pulse ox can kind of help diagnose it. CBC, you're going to look for a high white count, ABGs. So we're looking at air exchange and how much oxygen is bound to your hemoglobin. A blood culture and electrolytes. Or we're going to treat these with antibiotics, penicillin, erythromycin, cephalosporins, and terramycin. Analgesics, we're going to give Tylenol or acetaminophen. We're going to give expectorants to kind of help thin those secretions and make it easier to cough up. We're going to give bronchodilators like albuterol, ipratropium, and theophylline. They may need humidified or nebulized O2. And they may need anti-inflammatory respiratory meds like fluticasone and prednisone, and oxygen if needed. So they may need supplemental oxygen if they continue to have respiratory disorders. So some nursing interventions that you can do, you want to encourage your patients to rest. You're going to encourage them to turn, cough, and deep breathe every 2 hours. You're going to put them in a high Fowler's position. And if you're gonna turn them, you want to put them on their side. So if they have right side pneumonia, you want to put their left side. You want to put them on their left side. You also want to be able to assess their ability to move and expel secretion. So they may need suction set up so they can use a yonker. So you want to educate them on how to use that. You want to increase their fluid intake and teach them about an incentive spirometer. And we'll get into that a little bit later. And then you may need to do chest percussion and postural drainage. So chest for percussion, you want to kind of cup your hand, or for kids, they make little cupping devices to use. But when you have your hand cupped and you're like putting pressure, it's sending airwaves to kind of move that stuff around. And then this picture here is the postural drainage. So if you're trying to move fluid from, the right middle lobe, you want them on the right side to move it. So this just kind of shows that. Epistaxis is a nosebleed. So that's when you have a rupture of those tiny capillaries in the nasal mucosa. These are pretty common. They can be severe, but not very often. They can be caused by trauma. And trauma can be, if you break your nose, or people that pick their nose can get too far and rupture some of those vessels. You can have a systemic infection. You can have a local infection. You can have dry nasal mucosa. So if the air is drier up there, you're more likely to cause bleeding. Hypertension. So you think of all that pressure in your vessels. Can cause these vessels to rupture. You can have a nasal tumor, a blood dyscrasia, that's just a blood disorder. And if you use aspirin, you can get nosebleeds with this. So to treat a nosebleed, we're going to put them in high Fowler's, and we want them to lean forward. You do not want them to pull their head back and pinch the nose. All that's going to do is put blood in the back of their throat, and they're going to swallow it. And blood is not meant to be in the stomach, so they're going to end up throwing it up. So you want to have them lean forward, pinch their nose, and they can use ice to kind of help shrink those vessels. If it's severe enough, they may need a nasal package, what we call like a nasal tampon. So they shove this cotton up in there and it expands. And it just kind of helps put pressure on those bleeders. They may need a balloon tamponade, so it's the same thing. So they'll put like a balloon up there and they'll inflate it to kind of help compress those vessels. If they have epistaxis or have had a recent nosebleed, they need to try to avoid sneezing, especially if they have a balloon tamponade or a nasal package. They don't need to rub or blow their nose. You want to try to make sure that they avoid swallowing that blood. The patient does not need to remove any cloths or nasal packaging. They need to go to their provider. They don't need to cut the string to the packing. No aspirin or ibuprofen, because aspirin and ibuprofens are work as like an antiplatelet aggregation. So if they take aspirin, they're decreasing the amount of platelets that are going to be there to kind of clot that blood. If they have persistent bleeding or they have severe bleeding, they need to see a provider or come to the ER to get a nasal tampon put in. Ooh, okay, now we're going to talk about trauma and obstruction of the upper airway. So obstructive sleep apnea. On Moodle, there is an article that talks about obstructive sleep apnea. I highly recommend that you read it and look through those questions because you may see some of those questions on your exams. So obstructive sleep apnea, you have apnea, which is the cessation of breathing. You have hypopnea, that's abnormally shallow and slow respirations. You can have a partial or complete upper airway obstruction during sleep. And there are roughly 18 million adults that are affected, but 90% of them are undiagnosed. So when you have normal breathing, you still have air that can get through, but when you have obstructive sleep apnea, those airways when you lay down become blocked, and so your breathing is affected. Risk factors for sleep apnea are obesity. Males tend to have this more often. The older you get, the more likely you are to have this. If you have a nose condition, so if you have like chronic sinusitis, or if you've had nasal surgeries, this can be a secondary cause. If you have a receding chin, so there are congenital disorders that make your chin recess. So you'll see these people who have very recessed chins. This causes structural disorders, so that the jaw kind of slacks backwards. And then that can cause your pharyngeal structure abnormalities. So these patients that have obstructive sleep apnea are going to frequently wake up at night. They're getting woke up because they're almost snoring so loud they wake themselves up. They're going to have insomnia, so they don't feel real well rested. They're going to be very sleepy during the daytime. Um, they can have headaches when they wake up. They can even develop personality changes. They can be very irritable. They may be hypertensive, and they can have cardiac dysrhythmias because of obstructive sleep apnea. So how do we manage this? You want to avoid any sedatives or alcohol 3 to 4 hours prior to sleep. You want to educate your patients to lose weight if possible. They may need some type of oral appliance to kind of help keep their tongues and stuff from sliding backwards. Or they may need CPAP or BiPAP. So sleep apnea is a chronic condition, but you can treat your allergies. If you have a congenital disorder, like with your jaw structure, you can have some types of jaw structure or jaw surgeries to correct that. And weight loss. And then you can also, like I said, use the CPAP therapy. If you have an upper airway obstruction, you can have inflammation of the tissue. It could be due to dentures, aspiration. Your tongue can cause that. You can also have a laryngeal spasm. Signs and symptoms of an upper airway obstruction. So think upper airway. You're going to have stridor, lots of wheezing. They might even have be clutching their throat. This is that universal sign of choking. But if they have an obstruction, then they're going to have that universal sign. They may have an altered respiratory rate and character, so their respiratory status may change. They can become hypoxic and cyanotic. So how do we treat an upper airway obstruction? We want to open the airway, remove the obstruction only if you can easily reach it. Remember back to CPR training, you don't want to risk pushing that obstruction further down. So you can do a Heimlich maneuver. You can also give epinephrine or corticosteroids if they're having like an allergic reaction. So if you think of somebody that's having like an allergic reaction to peanuts, their throat and everything starts to swell and becomes obstructed, you can give them epinephrine or some type of corticosteroid to kind of relax that tissue. If this is not being effective, then you may need to trach them, or they'll need a tracheostomy. So with tracheostomy, we talked about trach care and suctioning, all that in first semester. A trach gets placed in that fourth tracheal ring. And then you have the straps. So you can still breathe, but like we had to make sure that we're doing our cleaning and all that stuff that you remember from nursing 1. There are different types of tracheostomy tubes. There's cuffed, uncuffed. There are metal, there's plastic, there's disposable. And then like these pictures here show the cuffed with the removable cuff and the obturator. Do you remember what equipment you have to have at the bedside? Think about it. So with a tracheostomy, you want to auscultate their lung sounds. You want to assess the respiratory rate, oxygen, and blood pressure. You also want to assess their level of consciousness. What's their skin color? Are they pale? Are they red? And then because this is in the upper airway, mucus can kind of build up in the tube. So they need a lot of humidification to kind of keep the secretions from occluding the tube. Laryngeal cancer is more common in men and occurs in adults greater than 65. A common cause of lung cancer is tobacco use, heavy alcohol use, chronic laryngitis, vocal abuse, GERD, and family history. So anything that's going to kind of erode or cause problems with the larynx, you can develop laryngeal cancer from it. Some signs and symptoms, you're going to have progressive or persistent hoarseness, dysphagia, hemoptysis. You have enlarged cervical lymph nodes, halitosis, which is just bad breath, and pain radiating to the ear, and weight loss. The treatment for laryngeal cancer is radiation and surgery. So they can do a partial laryngectomy, or they'll just need a temporary trach. They can do a partial total laryngectomy where they need a permanent trach so they won't have any voice, or they may have to do a radical neck dissection. Okay, what questions do you think you guys have? So as you're watching this and reading through the notes, think of some questions. You guys can email me. I don't imagine us being in lecture, so this is why I've prepared this. If you have any questions, this heads up, there is only one for both exams. So you'll have to go through and fill that out and want to figure out which questions that you'll have to study for this, but you guys can email me, no problem. If you don't have any questions, I'm going to end the video. And then you guys can just let me know if you need anything. Okay? All right. Have a good day.